I'm going to tell you a little bit about the advantages of having an integrated practice unit. Because as Joe has mentioned, we have to move from this traditional way of organizing around specialties or even around interventions to really focus on the patient needs. Patients with specific medical conditions that should receive care from a dedicated team. And that's what the IPU is all about. And that's why it's one of the key components of the value agenda, is how can you organize care around patient needs, patients that have specific medical conditions and they are seen by a care team, a multidisciplinary team. And so back in 2013, and later there was reinforced in 2021 by Professor Michael Porter and Thomas Lee, they proposed 11 features of an integrated practice unit. So you have heard in the definition, most of it, but care should be organized around one medical condition, not dermatology, but psoriasis. Or you can even do this with a set of closely related conditions, for example, different inflammatory arthritis or diabetes and obesity, for example, or a segment of the population, for example, elderly people with multiple chronic conditions. Now, care should be delivered by a multidisciplinary dedicated team that identify themselves as part of that IPU and also take responsibility for the full cycle of care for that condition. But in regard to patient, we should have education, engagement, monitoring, adherence, follow-up integrated into the care model. In terms of structure, they advise that the IPU should have a single management and scheduling structure, and the team should be co-located in dedicated facilities. It's very important to have a leadership, a physician leader, but also a care coordinator to oversee each patient's care plan. And it's very, very important that we should systematically measure outcomes, processes, and costs. And the team should meet not only to discuss care plans, but also the results of these measurements and feel jointly accountable for outcomes and costs. Of course, all those features are important, but we believe some are more important than others. So nowadays, we do not understand that co-location is mandatory, or that you have a single management and scheduling structure is mandatory. You have different models of IPU that you could find when you look at the application of this concept into practice. So for example, if you look at 7 European cancer centers, look at the different breast cancer IPUs. All of those IPUs have organized around medical conditions and have a multidisciplinary team, but they do not collect outcomes. They do not measure costs. So this is a very important feature for you to be called an IPU. And also patient education engagement, it's not part of this delivery model. So if you come to Latin America, we have published this paper on 70 healthcare organizations in 5 countries. That's the same. They all have multidisciplinary team, but a group of professionals is not really a team unless they have this dynamic of working together, discussing the care plans together, and improving care through systematic measurement of outcomes and costs, and feeling responsible for the results. So you have seen in the first webinar when Professor Paul van der Naat came to present, and he presented on Santio, on the Santio model, but he also has this, and Joe has presented this in the beginning, so it made my life much easier now. we have different models, have different ways of implementing IPUs. You can start with improvement teams like Santion. So each hospital has their breast cancer improvement team. It's not a formal unit. It's a team that is looking at data and it's improving care. And then you get more formal, and then you have the units like you see in San Antonio, so with the care chains. Or you can become more structured, as Joe mentioned, and then you have the IPU structure becomes dominant, but is still connected with the hospital, like SOPLUS or the Joint VASC. Joint VASC is the best example of IPU implementation in Latin America. I'll tell you a little bit more about it. And we can become an independent center like Diabetes or the Alexander Monroe for breast cancer, for example. So they are standalone integrated practice units. Now, let me tell you a little bit about Joint VASC. Joint VASC is a stroke IPU that has been established around 25 years ago in a city called Joinville. It's a 600,000 inhabitants in the south of Brazil. So 3 very young neurologists just left the residency program. They got into this public hospital and they found a lot of patients with stroke and very bad outcomes. And then what they decided to do just changed everything because they started collecting data. And they were awarded with the 2021 VBHC Prize from VBHC Center Europe. So Joint VASC has 3 main pillars. The first one is the stroke registry, the first stroke registry in Brazil. The second pillar is the stroke unit, with the core of the IPU that connects primary care, pre-hospital care, inpatient care, and post-acute care, and the patient association, which plays a major role in the sustainability of the model. So they collect the outcomes for 5 years for each patient, not only for the public hospital, but for all hospitals in the city, private and public, for 5 years. And they use the outcomes hierarchy. So they collect survival, functional status, quality of life, time to recovery, complications of treatment, and recurrence. And they promote professional care coordination over the entire stroke journey. They connect the transition from inpatient to outpatient care, and they plan long-term medical treatment, rehabilitation, and community integration. They follow evidence-based protocols, and they have been very wise when they stimulated the creation of the patient association. So this patient association creates a link between patients, managers, and healthcare teams. So yesterday, we had the annual forum where all those players come together to see what results we have achieved so far, but most importantly, what we are going to plan for the next year. And this is very important for continuous improvement. Also importantly, a representative of the patient association is in the managed committee of the IPU and has a permanent chair in the city's health council. So you guarantee that you have the community involved, but also the public managers who take decisions involved. Well, the results have been very impressive so far. We have seen a reduction in the incidence of stroke in Joinville of 37%, a 58% reduction in stroke mortality, a over 100% improvement in the functional status, and 83% of patients in the city are treated in this IPU, although 44% have a private insurance, but they prefer to go to the public hospital. And a very good and important lesson that we got from Joint VASC is that the less expensive place for you to send the patient is not the ICU, it's the stroke unit. Because those patients do not need more technology. What they need is early multidisciplinary care. They need rehabilitation, and that is very crucial for improving outcomes in the long term. They measure cost using TDABC, so they have access to lifetime costs, medical costs, and indirect costs of care. One very good example of how you can be data-driven in this approach is what happened during the pandemic, when there was the onset of the restrictions and the lockdown. So patient admissions fell around 36%. And then very early on, they could see it, and they got in contact with the doctors in the emergency department saying, hey, we are here, we are working, please send the patients, and also went to the media to talk to the population and inform them they shouldn't stay at home if they had any suspicion of a stroke. And very early on, they could get the patients back to be admitted to the hospital and improve outcomes again. So this is a very interesting way of looking at IPU, but also we have a network IPU, which is a different model, which is not in the 4 archetypes, which is a network of network. And it's very important for countries like Brazil, for example, where we have this continental country. It's not easy to have specialists all over the place. So the ParkinsonNet is a very good example of how you can create networks to connect to professionals, patients, and family that follow evidence-based care pathways and that measure outcomes and costs. And the results are really impressive as well. They can reduce bone fractures, hip fractures, reduce the incidence of admission in nursing homes, and reduce costs. There is another advantage, which is scalability. When you use the network approach, you can also move from one country to the other. For example, ParkinsonNet now is in the US with Kaiser Permanente, the same model, providing the same good results. So this is also a very good way of expanding geographically a value-based healthcare approach. So yes, there are lots of advantages of starting an integrated practice unit. And I would say that for patients, the access to specialized integrated care and also be more active in shared decision-making, having this opportunity, have better health outcomes and experiences, and be connected with people with similar needs is very important. In regard to the care team, it's much better to work in a collaborative, multidisciplinary environment with people with a shared purpose, but also that will provide a better clinician experience. You get to know your outcomes. And of course, it's an opportunity for you to improve your scientific and clinical reputation. In regard to payers, it's if you coordinate and integrate care, you reduce waste and the cost of care. Consequently, you get to know the outcomes of full cycles of care, and you can transition to innovative outcome-based agreement. And for the suppliers, of course, knowing outcomes in transition is important, but also you can start to reproduce in a better way the outcomes you got from clinical trials. Because when you move from clinical trials into clinical practice, there is this gap of uncoordination and fragmented care that many times avoids you from having the best outcomes you've seen in the trials. When it comes to the health services or the providers, we have to remember the virtual cycle of value proposed by Professor Michael Porter, where when you specialize and you focus on a medical condition, you get more experience, you become more efficient, you can innovate better, you can sustain a dedicated team, and you can improve your reputation, get better outcomes, and get more volume. Why is that important? Because volume is key for sustaining the integrated practice unit model. Let's remember Professor Elizabeth Teisberg. I love quoting her, and she says, there is no debate around the need to move from volume to value. The challenge now is how to do value with volume in order to sustain the model. So I will leave you with this quote from Professor Michael Porter and Thomas Lee. So why do we need integrated practice units? We need them because healthcare does not have to be chaotic. patients and families should not have to worry about coordinating their own care, and clinicians should not have to wonder who will provide the other services that their patients need. Thank you very much.
Thank you so much. That was wonderful. Also, your last, or the last quote is exactly, I think, by focusing on a medical condition with everyone that can have an added value in it it leads to more efficiency and actually lowers the cost and raises the quality.